A very good afternoon to you all. Myself, Dr. Sumedha Gupta, and on behalf of Voice of Healthcare, I would like to welcome all the viewers who have joined us. So, today, we are here to present the 10th episode of Detect to Protect, a series of awareness session in fight against the breast cancer, organized by Voice of Healthcare and supported by Zydus Life. In today's session, we'll explore about the vital insights on breast cancer from recognizing the signs and symptoms to importance of early detection, prognostic testing, policy advocacy, and the latest treatment options. So let's come together to empower ourselves with the knowledge that protects women's health. Before starting the discussion, I would like to share some facts about the breast cancer prevalence in India. Breast cancer in India possesses a significant public health challenge, accounting for about 14% of the global burden. The incidence is rising at 1.5 to 2% annually, with approximately 60% of cases diagnosed at advanced stages, which actually impacts the treatment outcome very severely. The average age of diagnosis is around 45 years, younger than the global average of 61 years, and survival rates varies widely. 70 to 80% in urban areas in comparison to 40 to 50% in the rural regions. Awareness of symptoms is really low, with only 20 to 30% women are informed about the disease and the less than 10% participate in the regular screening. Cultural barriers and stigma further impede timely medical help, especially for the women with a family history of breast cancer who actually are at 2-3 timer higher risk. These factors highlight the need for improved awareness, education, and the healthcare access to address the rising burden of breast cancer in India. And in the light of these stats and facts, to begin with the discussion, first I would like you all to please join me in welcoming our expert who is going to provide us with insightful information on understanding about the breast cancer awareness. I would like to welcome Dr. Rajit Rattan, MD, DNB Medical Oncologist, Ojas Hospital, Panchkula. Good afternoon, doctor. Welcome to the discussion.
Good afternoon, Dr. Gupta. Thank you so much for having
You're welcome, doctor. So let's begin with the discussion points. Dr. Rajit, if we talk about the sign and symptoms of breast cancer, so what are the most common sign and symptoms of breast cancer that women should be aware of?
I think the first and the most important thing is to feel if there is any lump in the breast, because that's the most common symptom as well as a sign for me. A breast lump is usually present in the upper outer quadrant. It can be in anywhere in the breast, just behind the nipple as well. But it's a painless, hard lump that you feel. If you feel that, you should go to a doctor and consult him. Besides this, there are other non-specific and some non-sensitive and a little rarer signs, like if there is any discharge, especially bloody discharge from the nipple. If there's any erosion of the nipple for some reason, that can be a pre-malignant condition. Sometimes the breast mass is over and about the axillary region, and that can also be painless initially and then subsequently may get infected and have pain. So the most important thing is that there's a mass in the breast and this is completely painless, which is the problem area for us, because patients do come to us only when they have some pain in the mass. So you have to just identify and recognize any danger sign. So an asymptomatic painless mass in the breast is a danger sign in itself.
Thank you, Dr. Rajit, for these insights. Moving ahead with the discussions, how can a woman differentiate between the normal breast changes and the potential warning signs of breast cancer?
That's a very good question. So there are some breast lumps which are seen while a mother is lactating. They are usually painful. They have cyclical pain with menstruation. There is usually some amount of fever associated with any abscess if you have, but these are all non-malignant cases. A quiescently lying, painless, hard mass inside the breast you have to rule out a malignancy or a breast cancer first. If you go to a doctor, the first thing that they'll do is they'll palpate the breast by themselves to have an idea where exactly the problem lies, followed by which there are investigations which you do. So if there's a young patient, you tend to do an ultrasound of breast. And if there's a old patient, a mammography or an X-ray mammography also suffices. But that's for the doctor to realize. For everybody else, for a general patient, for a general layman, any painless hard lump that you feel around your breast, you should be alarmed. Sometimes there is some nipple retraction associated. There are skin changes which happen a little later in the course of the disease. There's an orange peel-like appearance of the skin, as if the skin has become like an orange peel with small dots in it. That's also a warning sign that this may actually be a breast malignancy.
Thank you, Dr. Rajit, for providing us with these insights on the sign and symptoms part. And if we talk about the self screening and the screening methods, so what are the recommended guidelines for clinical breast examination if we also compare the Western guidelines and the guidelines according to Indian system?
I think our guidelines, although do not support it, but it's a general consensus among clinicians that we should start our screening 10 years before the Western guidelines, because our patients are younger, an average of about 10 years younger. So if I talk about self-breast examination, that should start as soon as you've started lactating, or even from the age of 25 years. So what you should do is you should check your breast monthly, stay, sit in front of a mirror, see your breasts, are they symmetric, feel them with the palm of the hands. We'll discuss that in a little later. But self-breast examination remains a good screening modality, especially for those who are willing to do it and who understand the procedure as well. Besides that, if you come to the hospital, the first thing that we do is we may do an ultrasound of the breast, or we may do a mammography of the breast, depending on the age of the patient. And that's pretty much a basic screening tool, followed by which, if we find there is a need to do investigations, we go ahead and do it. And majority of the times, the breast mass is non-malignant, which should be the case, and we refer the patient to a gynecologist or follow up them in later times.
Dr. Rajit, can you hear me?
Yes, I can. Can you hear me?
Yes. Since Dr. Rajit, you mentioned about the self-examination, so can you please elaborate us with the self-examination technique and how often women should perform it?
So every monthly, let's say first day of the month or the first Sunday of the month, you should sit in front of a mirror and see your breasts. See if the one breast is asymmetric, lying up, is at a higher level or at a lower level. See if there is any change in the contour of the breast. Take the palm of your hand and take the flat of your fingers and roll it around your breast and press it and feel if there is any mass. So what we do is we divide a female breast. If there's a left breast, we divide it into 4 quadrants. Similarly, a right breast is also divided into 4 quadrants. The upper outer, the lower outer, the upper inner, and the lower inner. And the fifth area is around the nipple, that is beneath the nipple, which is called as retroareolar. So try and identify a mass in a symmetric fashion in all the 5 quadrants and see if the breast consistency changes at some level. So typically you will feel the breast tissue being very consistent and should not have any nodularity or any lump feeling. If there's a malignant mass, you will feel it as a hard, stony hard mass, which is underlying your breast. So even from the from a breast mass which is lying above the malignant mass, you will feel that hard mass as well. So maybe if you press that hard mass, there is some discharge from the nipple as well. That can also happen. See for the contour of your breast. See and raise your arms like this and see if one breast stands from the other, which may be. There are other methods. This pretty much is the main crux of self-breast examination.
Thank you, Dr. Rajit, for these insights. And if we talk about the self examination technique and the major mistakes, or I would say the common mistakes that women do, can you please enlighten us with that as well? That this should be avoided while
So
doing the self examination.
So the common mistake that people do is they sort of press their breast very hard and they try and feel everything from their palms. Palms is not a good way of doing it. So your fingers and your thumb and the flat of your hand is something that you should try and feel your breast with. Try and press it, but not too firmly. And you should not look out for a breast mass. If you keep looking for a breast mass for an hour and get very finicky about it, you may actually find something which is not there. So all in all, just be apply a moderate amount of pressure over your breasts and see if the consistency is different or is there any underlying hard, bony, hard feeling that you're doing. What I commonly find among females is that they don't do a breast examination at all. So first, go ahead and do it rather than, even if you do it not in a correct way, you may still be able to find something. But the fact that you have to eventually come to a doctor once you feel that will reassure whether there is a mass or not. So my advice would be to at least go for it, because there is so much lack of sort of consistency among females that they should at least go ahead and do it. Don't worry whether you're doing it in a correct way.
Okay. Thank you for these insights, Dr. Rajit. And if we talk about the screening part, I mean, any new or emerging technologies in breast cancer screening that show promising effects for improving the early detection. So, can you please provide us with insights on these?
There are, I think initially we mostly relied on clinical examination as clinician. Then we had the advent of the ultrasound and the X-rays. Mammography is a simple X-ray that is done, bilateral breast mammography, and followed by which an ultrasound is done. But now, even in mammography, we have different techniques like tomosynthesis, which takes the image and gives you a CT picture of the whole thing. Tries to give you a 3D information of the whole breast. Then there are other X-ray digital mammography techniques which improve the sensitivity of the images. There's an advent of 4D ultrasound as well, which gives you a depth perception as well. And the best thing about, and the most exciting thing about mammography is now that we've started using at some centers artificial intelligence to detect any mass. It's still in research phase, but I believe detection of breast mass is something which is coming up in a big way, where we identify these small, subtle changes in the X-ray, which tell us that this point may be the site of origin of breast cancer after, let's say, 5 years. So I can tell you that you may have a breast cancer 5 years down the line and pinpoint it to an exact spot. So this is still in research, and I think I would like to believe that in coming 1 to 2 years, you may see it being done in clinics as well, in a long term, in a sort of a large scale as well.
Thank you, Dr. Rajit, for providing us with these insights onto that. Also, I would like to know, I mean, if we talk about the breast cancer prevalence in India in comparison to the region, I mean, the rural area and the urban area. So, what are the statistics or number that you have observed so far, and what are the reasons of prevalence of the breast cancer cases in urban area, which is really more than that in comparison to the rural one?
I think to give you a context about breast cancer incidence and its prevalence, the higher the developed area is, higher is the risk of breast cancer. A part of it has to do with the childbearing, the reproductive age group, and the estrogen exposure that we have. So, the highest incidence rates are in France, actually, where you have every 1 woman out of 8 women who are diagnosed with breast cancer, which is a pretty huge incidence rate to have. We are getting there, unfortunately. In our cities, we are seeing that there is an increase in the incidence of breast cancer, and I think the figure would be 1 in 15, maybe. But we've come a long way since a decade. In urban areas, it is still less because there is more childbearing, there is more sort of they feed their babies with their own milk, more lactation practices are seen. So the incidents probably are a little lower in that sense as well. But in India, if you talk about a general ballpark figure, it's somewhere about 1 in 25 females have breast cancer, and it is increasing, unfortunately, and we would like it to go in the reverse direction.
Thank you, Dr. Rajat, for these insights onto these prevalences. And if we talk about the early detection part, so can you please provide us insights and how important it is, or maybe I would say effective it is, if we it detect the breast cancer in early stages, how it influences the treatment part as well and the patient outcome?
I think there are lots of advantages to first diagnose and treat the breast early. The first and the foremost is the survival. We've seen that the early stage breast cancer patients do well. Most of them get cured of their disease. The recurrence seen with carcinoma breast and the relapses seen are lesser when the stage is less. That's the first important part, that you will get to live longer than you would otherwise have, and you will also have less recurrences. The second most important part is that if you have an early disease, you may not lose your breast completely. What happens with people who have large breast sort of tumor or have infiltrated the skin, that the tumor has infiltrated the skin, the breast removal, unfortunately, at that time has to be a complete breast removal. So, if a patient has a small breast mass rather, the excision has to be in a way that the excision happens in a way that the breast is not completely removed and there's only partial breast removed. That's one thing. There is also areas in which the early stage patients receive less therapies because they have less risk of recurrence. You can tailor their therapies to a way that they receive less chemotherapies. They will receive less of these targeted therapies as such, and there is less intensive treatment for them. However, if your tumor was higher staged, you will receive therapies which are toxic and more number of cycles and more number of therapies as well. And you will lose your breast completely. So these are your two major drawbacks if you have disease diagnosed at an advanced stage. The survival as well as quality of life both get hampered. However, if you do it in early stage, you can maintain both of these in a good sense.
And Dr. Rajat, if we talk about the diagnosis part, so what diagnostic methods are currently used to detect the breast cancer and which actually are very effective and help us to detect it very appropriately at early stages also?
So as I said, ultrasound and mammogram remain the two cornerstones of our detection. They will tell you where the lump is. Does it look malignant or not? It may not be malignant. And then is the role of a biopsy. You poke in a needle in a way that it doesn't affect the spread of the tumor. You have to be very careful about it. And then take out a sample and then look it into a microscope, stain it, put some assays and see how is it staining. These are the two preliminary tests we do: the imaging as well as the biopsy. Sometimes you need a special imaging. If you have a young patient who has a genetic tendency of having breast cancer, you tend to go for an MRI of the breast because there are chances that the patient may have more than one breast cancer lesion inside. There may be more than two, and bilateral breast may get affected at that time. After you've confirmed it's a breast malignancy, you've done your local scans, you've done your biopsy, you then have to stage the patient. And for staging, the best modality remains a PET CT scan, an FDG PET CT scan, which will tell us about the extent of the tumor not only locally, but whether it's spread to other areas or not. Besides that, you require patients' blood work, the routine tests that we do, CBCK, FTL, FTM, Sometimes we also go ahead and do a 2D echo to see if the cardiac functions are good enough for the patient. These are the preliminary investigations which we do, and I don't think we go beyond that. Only in very special circumstances we go beyond these tests.
Thank you, Dr. Rajit, for these insights and for sharing knowledge onto that. Moving ahead with the discussion, if we talk about the prognostic testing and the risk assessment, so I mean, what is prognostic testing and how it differ from the predictive testing when we talk about the breast cancer?
I think prognostic test is a test which will tell you how the patient will behave in future. Prognostic tests like ERPR, HER2 new status will tell us is this disease an aggressive disease or not. Sometimes the Ki67 is very high, which will tell us that breast lesions are proliferating very fast. So these are the tests which are done on the sample that we have taken, and imaging doesn't have a major role to play in this. Unless we don't do a biopsy, we will not know whether this is an aggressive tumor or not. The ERP and HER2 status are, in case of breast, also predictive. They are predictive of a response to a therapy. So predictive means that I know if I give hormonal treatment to this patient and I predict that she will do well. I can say it because I've done this predictive test. And similarly about HER2 new status, HER2 new status positivity means that the patient will do well to the anti-HER2 therapies that you have. So in breast, the distinction between predictive and prognostic factors isn't much, and there are lots of gray areas. So a predictive test is also a prognostic test in case of CNS.
And Dr. Rajat, if we talk about the genetic testing, I mean, who should consider the genetic testing for the breast cancer and what specific genes, I mean, like BRCA genes such genes are associated with the increased risk. So what are your views onto that?
That's a very good question and very important question pertaining to the present day circumstances. I think almost about 20% of carcinoma breasts have a family history, and out of that, in 15% we are able to identify some genes in these patients. When should we go for these tests? There are a few indications that I will list you. One is if a patient comes to you with a metastatic breast cancer. In whichever way it comes, you have to rule out whether there is any genetic component to it or not. Number two is whenever you have a young patient who comes to you, even in an early stage, and her age is less than 50 years, a very young patient coming to you, you should know that there has to be some other factor besides an environmental factor which is contributing to the breast cancer. And there's a specific variety of breast cancer known as triple negative breast cancer. Whenever there is no hormonal or any HER2 new marker present in the breast sample, is also the area where we do triple negative, is where we do genetic analysis. Besides that, if the patient has a family history of malignancy, has a first cousin who has breast cancer, or has more than two or more than three second cousins who have breast cancer, has had breast malignancy in mother or other first degree relatives, then there is an indication as well. There is certain ancestry in Jews called as Ashkenazi Jews as well. If a patient comes to you from that ancestry, you also tend to do your genetic testing. I think it is largely becoming an area where almost every patient is at some point of time offered a genetic testing when she has CFS.
And Dr. Rajat, if we talk about the latest treatment methods, so what are the current standard treatment options available for the breast cancer and how they have been evolved in recent years?
So conventionally, we had surgery, which was usually a modified radical mastectomy, was the standard approach for early breast cancer, followed by which there were the therapies like chemotherapy, hormonal therapy, and targeted therapy. Things seem to have taken a turn where we now titrate our treatment and tailor it according to the patient profile that we have. So now, if I have a patient who comes to me with, let's say, a HER2 positive patient comes to me with a tumor mass of 3 centimeter, I will not straight away go for surgery. I will first give them some therapy along with targeted therapy and assess the response of my therapy. If and After my therapy is completed, I will not now go for a complete radical mastectomy. I have the option of a breast conserving surgery followed by giving that patient local radiation. So what it now tells me is when I give therapy to that patient, I can assess the tumor shrinkage once it is removed. I will see what is the effect of my therapy as well. And if the effect is very good, I will stop after radiation, just give the maintenance HER2 therapy. But if I do not have a good, I'm not very, let's say, comfortable, or I do not get a good response of my therapy, I know that this patient will recur early in stage, and I will increase the treatment intensity after the patient undergoes surgery. Similarly, in triple negative breast cancer as well, we initially only had chemotherapy option in our kitty. Now, with the advent of immunotherapy and trials showing that immunotherapy along with chemotherapy benefits these patients in a way that the tumor shrinkage is faster, more number of patients derive benefit with this therapy, and more number of patients live longer with these therapies. So a lot of stuff has changed in carcinoma breast, and a lot of new therapies have come in. But the idea remains that now you do not treat 10 patients equally. You see their characteristics and take decision in patient by patient basis, and then move ahead.
Thank you, Dr. Rajit, for these wonderful insights on the treatment part. And I think it's really enlightening to know such latest development in terms of breast cancer treatment. In the end, to conclude, Dr. Rajit, I request you to please provide us one take-home message for the people who are who are diagnosed with the breast cancer recently or at the verge of this disease.
So this October being a breast cancer awareness month, I my message to survivors of breast cancer would be to keep going to your doctor, keep the follow up of your disease in check. Try and lose weight. The disease as well as the treatment that comes with it tends to put on patients tend to put on a lot of weight because of this therapy, and excess weight, if you have it, tends to increase your risk of relapse as well. So try to remain fit while you are in follow up. Enjoy your life. Help everybody around you know that this disease is conquerable, and you should not get worried about it. We have a lot of patients in our clinic who are hesitant to do biopsies, who are hesitant to go ahead and get treatment. Be a beacon of light for them. I often engage my survivors to talk to my new patients who have a lot of uncertainties regarding treatment and other things. So help as many women as you can so that they can also live a fruitful, happy life like you are.
Thank you, Dr. Rajat, for such an positive advice and recommendation. And I think this is going to be really valuable for the people out there. So, in conclusion, our objective for today's discussion was to explore and emphasize the importance of breast cancer by integrating insights on recognizing the signs, symptoms, the significance of early detection, genetic testing, and the treatment part. And I'm confident that our expert has addressed this crucial topic very comprehensively and effectively. I would like to extend my gratitude to Dr. Rajat for your insightful contribution and for sharing your expertise with us. Your participation has been really valuable, and we deeply appreciate the time and knowledge that you have shared. So, thank you so much for joining us today.
Thank you, Dr. Thank you so much